Next topic is a panel discussion. Moderate this session, we have Dr. P.K. Thomas with us. Dr. P.K. Thomas is our course coordinator also. He is a consultant respiratory physician in Apollo Hospital, Vijaya Hospital, Vijaya Health Center, Balaji Hospital and Bharani Hospital. He has, I think most of us know about him, and he has conducted various TB screening programs and several sessions of smoking cessation programs mainly in villages. And he is known for his numerous papers presented both in national and international journals. The panelists for this COPD session are Dr. Rajagopalan, Dr. Sangeeta, Dr. Sadanandam and Dr. Sridevi. I request all the panel members to come on stage.
A very warm good morning to everybody. Is this working? Yeah. At the outset, I think I'd like to thank Dr. Gauri Shankar for having given me the opportunity to be here. It's a great pleasure and it's a privilege. And if you have a panel like this sitting across to me, I think it's a greater privilege to me. The man sitting on my right is Professor Rajagopalan. I met him for the first time on my first day in medical college. I don't know if he remembers. Under the tree in MMC, which everybody knows, with that conventional cup of coffee and the little guy running around here and there. That's where we met, and this is a friendship that's sort of blossomed over the years, and I think it's my proud privilege to be associated with him. He's, leave alone his academics, I think everybody knows his academics. I don't think I'll talk about him, but I think as a person is really what I respect him the greatest, and it's been an absolute privilege to have him with me for the past so many years. It's really a privilege indeed. I'd like to introduce two other people together. Dr. Sangeeta and Dr. Sridevi are the brains of the Department of Pulmonology, SRMC. They are the brains and we are probably the sort of nerves running out of the brains. So they are two very intelligent people who are highly respected in the fields of pulmonology and who are people whom we resort to when we have trouble. If you have a doubt, you go and ask Sangeeta or you go and ask Sridevi, they'll come up with an answer to you. So those are the type of people that we have with us, and it's indeed a pleasure and a privilege to have both of you with us. Dr. Sadanand is a cardiologist with SRMC in Ramachandra Medical College. Sir, it's a pleasure to have you with you as well. The task that's been given to me is to moderate a session on COPD. And I think it's interesting that COPD has undergone the sea change from 2000. If you take a 2000 definition, if you take today's definition, I think you will go from optimism to pessimism, from death to life, from darkness into light. That's really what it is. COPD has been transformed over the past 10 years, not only by the medications that we have, but also by the fact that we understand this disease better. Because we understand that this disease is multifaceted, multi-oriented, and we'll try to split it up into certain segments so that we can analyze it on the panel today. We will also talk about the various comorbidities, the cardiovascular aspects especially, which I think will be contributed to. We'll begin with the definition of COPD. I think if you take a recent definition, it will say COPD is a preventable and treatable disease. Now that's very interesting because you start on an optimistic note. Whereas if you take a 2000 definition of COPD, it will say that it's a disease that is characterized by airflow obstruction that is not reversible or very partially reversible. So I think you have moved on this sea change, and I think I would like one of the panelists to try and comment on this, the fact that we have moved on this definition. Is there anything in the definition that is left out or anything in the definition that we need to add to?
The current definition has taken in all the modalities into consideration. It has taken in saying that it is preventable. So there are strategies where we can intervene and try to prevent a whole lot of morbidity, not to talk about the mortality. And then it is treatable. So earlier it used to be like we don't have an option for them, but you have been through all the lectures yesterday and today, so we know how to diagnose, we know how to treat, and even in an end-stage disease, you have an NIV which is portable and which patients can take home, so it is treatable till the end, till the very end, it is treatable. And then it is a multi-system disorder, so it involves, it is not just a disorder with comorbidities, it is a multi-system disorder wherein you have an involvement of almost all the systems, your skeletal system, your cardiovascular system, your mentation, your psyche, all that. So the current definition, I feel, is taken in all aspects of the disease into the play.
Well, I think that's very interesting in the sense that if you take COPD as such, apart from the definition, I think if you want to make a diagnosis of COPD, you obviously resort to what is called a spirometry. There are a lot of people who will argue and say, your definition says that COPD is a irreversible disease, which is either irreversible or partly reversible. But at the same time, if you take the early trials in COPD, like the ISORD and the Euroscope 1 and 2 and all those things, they used bronchodilator reversibility as a yardstick of assessing all their clinical trials in respiratory medicine. And that's the reason why you will find that prior to 1995, I think we understand that all the trials have failed with COPD. Plain bronchodilators, ICS, all those things have failed simply because we used only bronchodilators as a marker. The bronchodilation as a marker. Today, as Dr. Sangeeta very rightly said, we have a composite index of COPD as such. COPD is not only reversibility and airflow reversibility. COPD is dependent on a lot of other things. If you take the 2013 guidelines for COPD, it's been released already, you will find that there are two other entities other than the FEV1 FVC that we've been talking about for such a long time, which we still are not very sure whether it's a very pertinent way of looking at COPD or not. We have also included patient scores, and I think that's a very important thing. You have the CAT score, which has just got 6 questions to it, and you can answer and you can total down below. Or you can take the MMRC score, which is the British Medical Research Council score, the MMRC score. On the other hand, we have exacerbations which are sort of plotted against the other. And I think if you look at the sort of graph for COPD, the ABCND that they have in the 2013 guideline, that's really what it will tell us. So they have exacerbations on that, and I'll ask Dr. Rajgopalan to comment on the fact that we have included a lot of other things in the definition of COPD, like, as I said, patient scores and also the exacerbation scores.
Before I go into that, actually, we should also have, I should also want to tell about the burden of COPD. Just like yesterday we were discussed about the asthma burden. COPD burden is a huge burden. By 2030, they say about every third death they suspect it could be due to COPD related. In India, we don't have a proper statistics or a data, but as such, about 20 million people are suffering from COPD. Again, there is a data available whether all these COPD patients are receiving proper treatment. That no way we can check it up. But if you look at the market, the drugs that are used for COPD doesn't reflect the number. So most of the patients, not even 20% of the COPD patients are receiving the optimum therapy. So in that way, I think that we have to create more and more awareness. He was talking about, before we go into the diagnosis, this is one thing we should know. And I think we'll start like a textbook. Risk factor, would you like to comment about the risk factor? I think Dr. Sridevi will talk about the risk factor in COPD, so that we will go like a textbook thing. That will be better.
Okay, thank you, sir. As all of you know, smoking is the most common risk factor for COPD, and it increases as the number of years of smoking increases. And also it's not only the direct smoking, but also the passive smoking also increases the risk of COPD. So though, the number of smoking years increases the risk of COPD, but when you see the data, it's only 10 to 12% of the patients who smoke develop COPD. So what about the others? So probably there's some other factor which is, also related. So that's when they came up with probably there could be some genetic tendency that could lead to COPD. So the first factor, risk factor, is definitely smoking. The smokers are at increased risk compared to non-smokers. And the other factors are indoor air pollution and outdoor air pollution. So indoor air pollution, especially the women in the rural areas, they're exposed to biomass fuel. So they are at increased risk. Then the occupational disorders, especially the coal miners, they're exposed to the coal dust and silica. All these people, they are at increased risk of developing COPD as well. So when coming to the genetic factors, the alpha-1 antitrypsin deficiency is associated with the development of COPD. So though the percentage of the people who develop alpha-1 antitrypsin deficiency is less in Asians and Africans, it is more in the US. So about 5 in 3,000 people may develop, they are at increased risk of developing COPD due to alpha-1 antitrypsin deficiency. So these are some of the risk factors which can lead to COPD, but the number one in the list would be definitely the smoking.
I think Dr. Piketty must tell about this smoking COPD and non-smoking COPD with reference to the Indian context.
Well, I think there's a huge difference between smoking COPD and non-smoking COPD, and I think you can put a geographical divide between this. If you take the West, for example, the West is 85% smoking. If you talk about non-smoking COPD in the West, it will be only occupational. If at all there is an occupational element to that. But in our country, I think over the past 10 years, we have come to discover that there is a very high element of non-smoking COPD. There are studies from the Chest Research Institute in Pune, for example, which will tell you they've done studies on non-smoking COPD, and especially COPD in women who lived in a single tenement, had a small place to live in, and they did everything there. They ate there, they slept there, they cooked there, and they did everything there. And the burning of fossil fuels, for example, and I think it's become an established entity today. Not only female COPD, but also you have non-smoking COPD, which I think is so very important. I think we have played a very major role, Indians as such, played a very major role in establishing this non-smoking COPD today. It really looks as though the non-smoking COPD does behave like a regular COPD, but then as I said, 10 years is too short a time in the period of a disease. So I think it's only the next 10 to 20 years which will tell us where this non-smoking COPD is really taking us. And I think it's important to know that. If you have a single exhaust in that tenement as such, you bring down the COPD by at least 20%. I'm sorry, excuse me. By at least 20%. So non-smoking COPD is a hugely preventable COPD. And I think that is the thing, that the lesson that we really learn is that non-smoking COPD is very, very preventable. All that you need to put a small exhaust in that, you'll bring down the percentage by a huge level. And I think that will make a huge difference as far as that is concerned. So I think in India, we have this complexity of both these things. Whereas in the West, they have only smoking COPD. But here in India, we have multiple levels as such, which will tell us what are the smoking things that we need to do to have COPD as such. Now, having said this about COPD and talked about smoking and non-smoking, symptoms of COPD, what do you think will be the symptoms of COPD? And I think that is very important for us to understand. And I think the symptoms are something that are very, very necessary for us. And I think I'll ask Dr. Sangeeta.
The patients usually present with a cough which is recurrent, or they might be having an exertional breathlessness. Usually the exertional breathlessness component is very late. It starts so slowly and it progresses so gradually that the patients don't realize that they have a difficulty in breathing. And they tend to ignore it, thinking they are aging or they have worked too much. Those are the excuses that they come out with. And this recurrent cough with expectoration also, we need to probe the history, because they're small symptoms where they're not going to go in directly to a specialist. It's a local physician that they're going to go in. 3 days of medication, there's a suppression of cough. It's just that all these symptoms over the period, which is unidentified, which is undiagnosed, which is going to add on to the severity of the disease by the time they land up in the clinics for the diagnosis of a COPD.
Well, we understand that cough and breathlessness are the most important things we're looking at. Cough is a very easy symptom to understand and realize, but breathlessness is something which we may not be very aware of at the beginning at least, and we could attribute it to a lot of things like fatigue, like aging, like simply not exercising at all. And if you're not going to walk whatsoever, then how are you going to know what your exercise tolerance is? And I think that's again very important. And I would like to ask Dr. Sadanand what sort of symptoms that his patient would get when he has, when does he suspect COPD as such?
Always there is a overlap of symptoms between cardiology and pulmonology. Similarly, like COPD patients comes with generally cough, even heart failure patients comes with cough and exertional dyspnea only. So now as a mandatory thing, most of the hospitals are doing pulmonary function tests when they come up with such as symptoms to demarcate between the COPD and heart failure. So that's the way how we can differentiate so far. And routinely we have to subject the people for echocardiogram and a pulmonary function test so that we can differentiate between both these things clinically.
Well, I think that is very interesting in the sense that a lot of people may sort of land up with the cardiologist if they do experience breathlessness, and I think they will be able to understand how to go about this as far as the cardiological aspects are concerned. We also understand that in advanced COPD, which we'll talk about this a little later, we look at other things like echocardiographic criteria, pulmonary hypertension, and things like that. So once you suspect COPD, then I think you need to investigate the COPD. And what sort of investigations will you do really?
So first, a good history is the most important thing. Like as Dr. Sangeeta has already pointed out, a patient present with chronic cough, cough, breathlessness, with or without sputum and wheeze. But most of the cases, what happens is like the patient, they tolerate dyspnea well and they decrease their level of activity and come to the clinician only when late in the disease stage, when it is a moderate to severe COPD. Only then they seek the medical advice. That is a problem. So they come with an acute exacerbation. So at that point in time, it becomes very difficult to differentiate whether it is really a COPD or we're dealing with acute exacerbation of asthma or a cardiac cause. So, it's the history, as I said, is very important. Then the clinical examination of the patient also goes hand in hand. So most of the patients with COPD, they have, the pointers towards COPD, like increased respiratory rate, and they have prolonged forced expiratory time. That is most important. So normal people, they are able to empty out their lungs very quickly, less than 5 seconds. But in patients with COPD, because of the airway narrowing, so they take longer time to exhale. So, and then they have a barrel-shaped chest, on auscultation they're present with wheeze. So once you know, yes, we are dealing with probably a case of COPD, also go into the past history and the personal history of the patient. So invariably there'll be smokers. So any middle-aged with a smoking history, with all these symptoms and the pointers of the examination towards COPD, then think of COPD, and then you have to subject them to some investigations. And the cornerstone for the diagnosis of COPD is spirometry. So it not only helps in establishing the diagnosis, but also you can grade the severity of COPD by doing a spirometry. And also it helps to differentiate from asthma by doing a reversibility testing. So spirometry, I think yesterday there was a session on spirometry. So you look at the expiratory loop and see there's a caving in of the expiratory loop. So if the FEV1 to FVC ratio is less than 70%, you diagnose a patient to have COPD, and then based on the FEV1 values again you grade the patient into mild, moderate, severe, and very severe. So by giving a short bronchodilator and then repeating the test after 10 to 15 minutes, so if there is a good reversibility, then you mark the patient as having asthma. So reversibility is like if the patient is able to, if the FEV1 value increases by 200 ml and by 12%, then the patient has asthma. If it is less than that, it means the patient is having COPD. So spirometry is a cornerstone for the diagnosis of patients with COPD. Also, X-ray should be definitely done in a patient with COPD. It is to rule out the other things. So a patient with COPD will show hyperinflated lungs and the low flattened diaphragms. Typically, you would have seen a tubular heart. So in lateral view, increased retrosternal air space. So it is more to rule out the other conditions, like if you're dealing with any complications of COPD like pneumonia or pneumothorax, and also they rule out any malignancy because he's been a smoker for so many years. So has he developed any mass, or to rule out any occupational causes like ILD or cardiac complications like a pulmonary edema. So to rule out all those things, you definitely need a chest X-ray. So blood investigations will show polycythemia, because of hypoxia, the erythropoietin will be released, and so most of the patients will have polycythemia, but some patients may present with anemia as well. So total counts may be elevated if there is an acute infective exacerbation. So these are some of the tests which you have to definitely do for the investigation.
So I would like to add, in the early stages, because two speakers they already spoke, in early stages, COPD is grossly underdiagnosed. Am I correct? Right. That's the thing. Late stages, most of the time they present they present with an acute exacerbation. That's the time we make a diagnosis of COPD. Early stages of COPD, grossly underdiagnosed. Why? Even spirometry is grossly underutilized because there are a lot of misconception about this spirometry. Even yesterday also, from the general medicine side, he was telling about the cost of the spirometry, difficulty in doing all those things. It is not so. It's such an easy test now. I think everybody should make it as a punch, just like an ECG should be used on day-to-day practice, so that we diagnose COPD much earlier. Am I correct?
Yes, I think so. I think we should make this appeal here to this audience to kindly utilize more spirometry and probably utilize as much spirometry as you use your sphygmomanometer. And if you're measuring the blood pressure, you can measure the lung volume as well. After all, you have two organs sitting side by side in the chest. And I think you need to understand that measuring some index of function of both these organs are very important. So please do spirometry. It's very simple to use spirometry. Today, if you don't have a complicated spirometry, you have what is called a Pico 6, which is the which is the test which can be done in one blow. So you can use them in patients who are unable to complete spirometric procedures, but I think this would be a clear appeal from all of us sitting here that you please utilize spirometry and use spirometry more as such. Sir, I would like to ask you whether you routinely use spirometry in your cardiovascular patients who present to you with cardiovascular failure, for example.
So it's like previously we hardly use pulmonary function test. Actually, as a layman also, we never used, we hardly use pulmonary function test. But as the experience grows, we are not able to, initially there were so much of difficulties in differentiating between the heart failure and the COPD component. So now it's almost all patients who are present with exertional dyspnea, as a part of workup, we subject the patients for pulmonary function test also. So even always there is a overlap between the heart failure and COPD. Both are smokers, both will be having coronary heart disease, and on top of it they'll be having COPD. So it's very difficult if you keep on diuretics, the response shown by the patients will be very poor only. So those type of patients, definitely we subject them to pulmonary function tests. So it will be an addition and definitely a useful tool for us to bring the patient to the normalcy of life.
I think another thing that you can do is to use spirometry to prognosticate your CCF, for example.
Yes,
if you start with a low FEV1, for example, you have a poorer prognosis than when you start with a higher FEV1. I think that's been shown by ever so many studies. If you start off your CCF with a lower FE1 FVC, you have a much worse prognosis than if you start off with a better FE1 FVC. And the same goes for all the other markers, including CRP. We know that If you start with a high CRP, you have a greater mortality than if you start with a lower CRP. So I think these are indices, which means that spirometry is used around the board, across the board, in patients to whom patients present with breathlessness, whether they are cardiologists, whether they are pulmonologists or general physicians. I think the spirometry is an absolute must, and this is, ladies and gentlemen, an appeal from us for you to utilize spirometry much more than we are utilizing here at this point of time. Now, once you get the spirometry done and have this process as such, what is the first line of treatment that you would like to give these patients?
For those patients who come in at an early stage and we are able to detect them at the mild or moderate and they are stable, then we would like to initiate them on bronchodilators. So we have two options. We have the LABAs, which are the long-acting beta-2 agonists, and you also have the muscarinic receptor antagonists. So we can use these two groups. For a patient who is just coming in and there is a diagnosis of COPD stable, there is no need to initiate immediately on an inhaled corticosteroid. Most of the studies say that in the initial stage, they don't have a role. So you can use a combination of a LABA with tiotropium, which is a long-acting muscarinic receptor antagonist, or you can try just one of them if their symptoms are not much. But it is very important that we teach them the technique when we're using an inhaled bronchodilator, because most of the times the patients are carrying with them the right medicine, but what is lacking is the right technique. So the medicine is there, the patient is using it, but the delivery is not there. So you need to spend some time to teach the technique so that there is an end organ delivery of the drug and there is an action of the drug. If a patient is coming with recurrent symptoms, recurrent exacerbations, then they are the people who we would like to add in an inhaled corticosteroid, because we know that here again it is the inflammation which is the basic pathogenesis behind the COPD. So when we have an continuous inflammation which is manifest clinically as an increase in the exacerbations, then we would like to add on an inhaled corticosteroids on these patients. So usually most of the patients, they are able to be managed with a combination of inhaled corticosteroids, long-acting beta-2 agonists, and a long-acting muscarinic receptor antagonist.
Now basically, I think what Dr. Sangeeta has talked about is called the triple drug therapy. You use all the three drugs. You use an anti-muscarinic, you use a LABA, and then you use the ICS. The question would be, if you have the choice to use it singly, what will you be using? And I think that's very important. I think it's important for us also to understand that all societies will recommend the antimuscarinic agent as the agent of choice, which means you start with tiotropium. You start with tiotropium, use it once daily in the night. Tiotropium is available both as an inhaler and as a dry powder. And please understand that India is the only country in the world to have an inhaler with tiotropium. No other country in the world has tiotropium as inhaler. Tiotropium is always dry powder everywhere else in the world except in India, and we are not using it well. So I think we need to use the tiotropium first, and that's important. If there is one drug that can be used here in COPD, in all patients of COPD, across the board, all associations, all guidelines will recommend bronchodilators and will recommend tiotropium as first. To the tiotropium, you can add the long-acting beta agonist that she was talking about. The problem with the long-acting beta agonist today is that we have very few brands of only isolated long-acting beta agonists. That is the problem today. We have only salmeterol. We don't even have formoterol. If you want to use only the long-acting beta agonist, we don't have too many drugs. That's a real problem with us today. There are only combinations of the ICS and the LABA, which means invariably you land up with triple drug therapy here, and that's important. So I think if you go off the tiotropium, if you think the tiotropium is not important, your next step would be logically to add an ICS and a LABA, which means that you'll be going with triple drug therapy. And how long do you go with triple drug therapy, and how do you prognosticate patients with COPD?
No, but I feel the second ideal step will be to use a ultra LABA instead of going into, leave alone the cost, because here we are, when you weigh the benefits of that ultra LABA and inhaled corticosteroid, how do you rate them? I feel the second step will be to use an ultra LABA along with the tiotropium rather than adding an ICS and so that getting into the problem of the corticosteroid.
Yes, I think you've broken away from the guidelines in talking about day-to-day practice today. If you want my practice as such, I will tell you that I will use this ultra-LABA first, and the ultra-LABA we have with us is a drug called indacaterol. If there is one revolution in the pharmacology of COPD that has happened over the past 10 years, it is indacaterol. There is no question about it. Indacaterol is an ultra-long-acting beta agonist. Ultra long acting means it acts once a day and it acts for 24 hours. It's a dry powder inhaler that is available. It is a wee bit expensive, but mind you, for patients with COPD, it is literally nothing. It has revolutionized the lives of so many patients with COPD as such. So I think his question is very right in the sense that if you take the guidelines, you take practice, there's always a dividing line between them. And that dividing line in my case would be, I would use the ultra-LABA first and then probably add the tiotropium to that. So if you're looking at the ideal therapy for COPD today, you need to use the ultra-LABA, which is indacaterol, that is available today, and then you need to use the tiotropium. And both are available as dry powders, you can use them very conveniently. There is no problem to that. What drugs can we add on to these?
The next way to add a ICS.
Now the NICE guidelines will tell you that you can add the ICS at a 50% FE1 FVC cutoff. If your FE1 FVC is less than 50% of predicted, you can add the ICS. There are problems, of course, when you add the ICS. We understand from the TOD study, for example, that ICS will increase the incidence of pneumonia, for example. Very, very classic indication where they've used fluticasone salmeterol and found that the incidence of pneumonia was high. Though they were able to bring down the incidence of death by about 17.3%, which is not very statistically significant, they found that the incidence of pneumonias are high. So we need to be cautious with the use of the ICS as such, and retain the ICS, as Dr. Sangeeta said. When you really run into problems and you're not able to control your patients, when your FE1 FVC are dropping, probably dropping below 50% of predicted, then you add the ICS to that. So you have the ultra-LABA and the tiotropium. To that you can add these drugs and then probably add the ICS at the later date and then finish this armamentarium as such. Now, how about the use of oral drugs? I'd like somebody to comment on oral therapy.
No, before that, I think Sadanandam can talk about the safety profile of using this beta agonist in a cardiac.
Yes, this nowadays, whatever available thing, inhaled LABAs are very specifically acting on the pulmonary receptors, and the adverse effects previously which are been encountered in oral beta agonists, no? All those things have been come out with this directly acting inhaled beta agonist. We rarely come across with all the previously encountered side effects like tachycardia and tachycardia precipitated cardiomyopathy or tachycardia precipitated heart failure. All those things have been overcome with these inhaled LABAs.
I'd like somebody to comment on the side effects of the beta agonists by themselves, the short acting and the long acting as such.
The short-acting beta agonists usually, when the patient keeps on using the drugs for a long time, they complain of tremors, palpitations, and also like increased continuous use of the short-acting bronchodilator like salbutamol also causes the receptor tolerance. That is, the receptor will be occupied with the drug, so they will not be available for action. So the patient will not have any benefit of that. So for using after a long period of time. So, and also the patients also complain of also have hypokalemia, and therefore they can be used as a treatment for hyperkalemia. So long-acting bronchodilators, they are like quite safe, though they have some side effects, but relatively because they are used as twice daily, like long-acting like formoterol and salmeterol. So they have relatively few side effects because they are used as twice daily. And when we talk about what to choose between salmeterol or formoterol, so better to choose formoterol because it has rapid onset of action as compared to formoterol.
I think the distinction between salmeterol and formoterol is very nicely taken. The basic difference between salmeterol and formoterol is that Both act for 24 hours, as she very rightly said. But formoterol has got a faster onset of action. Formoterol acts faster, almost as fast as salbutamol. There are studies comparing salbutamol and formoterol, and they found that the same level of bronchodilation is achieved in the same time with these two drugs, formoterol and salmeterol. And that is the reason why in asthma, for example, formoterol is used both as a controller and a reliever. You have the so-called smart approach to asthma, where you use formoterol simply because it acts faster. The other and the most important thing with formoterol is that formoterol has got a dose-response relationship, which means you increase the dose of formoterol, you get better bronchodilation, whereas you increase the dose of salmeterol, you get only side effects. Salmeterol has a flat dose-response curve. Formoterol has got an increasing dose-response curve, which obviously explains the reason why all over the world today, formoterol is the drug that is preferred over salmeterol at this point of time because of the multiple advantages that you have. The caveat is that formoterol is sometimes associated with cramps. I don't know how many of you have experienced, but formoterol can cause cramps, and I think once you do have cramps with formoterol, I believe the pharmacology tells you that it's probably a class effect, which is felt with all the beta agonists, the salmeterol included. But you find very little cramps with salmeterol, but then formoterol does induce cramps, albeit in a very, very, very small percentage of patients. You may find that the formoterol can produce these sort of cramps as such. Oral drugs, anybody wants to comment on what oral drugs would you use?
One more thing. I would like to add here, Dr. Sridevi has pointed out one thing. Frequent use of this short-acting SABAs produces some sort of receptor down-regulation. All of us have observed that in our practice. Patient coming and telling, sir, I was using some salbutamol in errors. Now it is not acting as, it is not as effective as it is. How do you separate thing? Can any of the PGs can tell? Give an answer for this? If the patient tells, you can correct it. Simple. Very simple. Immediately we need not think about adding one more drug. A single dose of corticosteroid, about 1 milligram to 1 milligram or 0.5 milligram per kilogram body weight. 40 milligram, if a patient is having 40 milligram, you give a prednisolone, you get reset. That's the treatment. If it is really due to receptor blockage.
The phenomenon is called tachyphylaxis. And you can reverse it with a single dose of cortisone, about 1 to 2 milligram per kilogram body weight, it can be reversed. I made the appeal for spirometry. I make one more appeal today, and that appeal is to use as little of the short-acting beta agonist as you would like. And I think that's extremely important. Number 2, please use less and less and less of this drug called salbutamol. This drug called, if Cipla is not around anywhere here, I will use the word Astelin because that's what it's known by. Everybody knows Astelin, very few people know salbutamol. And I think that's extreme. That's a very bad sign, really. It's a huge, very, very bad sign. I still remember addressing one of these, attending one of these meetings of this company where they asked them, why don't you withdraw the short-acting beta agonist? Why don't you withdraw the drug starting with the A, for example? And I still remember the medical director got up and said, Dr. Prasanna, if you ask me to withdraw this drug, I'll have to find another job. My company will close down. And that's the volume of the short-acting beta agonist that we use. You see any person who is wheezing, COPD, IPF, bronchial asthma, he'll hold up the short-acting beta agonist in his hand like he's holding up the tricolor on Independence Day. That's what it is. And I think that's the worst part of the whole affair. And I think my second appeal to you, ladies and gentlemen, is to use as little of the short-acting beta agonist as possible, because we have excellent long-acting beta agonists that are available with us. Please use the long-acting beta agonists, which are 20 times safer than the short-acting beta agonists. And next time, please do not prescribe a short-acting beta agonist in isolation, because the minute he takes a short-acting beta agonist, he will know what is working, and he will go back to his chemist again and again and again. And the only person who will sort of benefit is the person who has made this drug A. And I think it's important for us to understand that we need to use less of this, and I think it's a very, very vital message that I'd like you to carry, because we understand that there's huge level of toxicity, especially cardiac toxicity, supraventricular arrhythmias like supraventricular tachycardia, all these sort of things are important, atrial fibrillation, flutter, all these things are extremely important, especially if you have all the comorbidities that in COPD that we're really talking about. So I think having said all these things, I think, shall we progress with comorbidities? We will talk about COPD and the comorbidities of COPD. The main comorbidity would be cardiovascular disease, and I would like Dr. Sadanand to talk on what he thinks are the basic cardiovascular mortalities that we look at COPD. I'd like him especially to try and tell us how much of a tool echocardiogram is in sort of diagnosing these patients who are at risk, how much of the right ventricle is really involved in patients with.
In case of severe COPD, slowly the pulmonary artery pressure starts going up because it has to, right heart has to pump against a poorly compliant great vessel, that is pulmonary artery, when compared to the systemic vessel. Once the COPD sets in and it does its work and causes the pulmonary artery compliance goes, very poor compliance of the pulmonary artery occurs. So RV has to start pumping against the forcibly against the poorly compliant pulmonary artery. Slowly the pulmonary artery pressures goes up, involving the right heart failure also. Slow, and once the pulmonary artery pressures goes up, so tricuspid, RV has to pump against forcibly against the pulmonary artery pressure, which leads to backflow of the blood into the right atrium also across the tricuspid valve. Initially there will be compensatory work by the right ventricle. Once the pulmonary artery pressure goes more than moderate pulmonary artery, that's more than 50 mm of mercury, RV starts failing slowly. So once RV starts failing, they will start developing clinical symptoms like pedal edema, abdominal distension due to ascites or tender hepatomegaly, and JVP will go up, and finally they will have a generalized anasarca. Those are the clinical symptoms that patient presents with the COPD and carpulmonale. So initially before 1995 there is coming to the investigative part of the thing, echocardiography is the cheapest non-invasive mode of investigation to get about the know about the pulmonary artery pressures. There are various methods used to assess the pulmonary artery pressures, but generally we go with the RV systolic pressure, which is measured across the tricuspid valve. The pressure difference between the right ventricle and the right atrium gives clearly about the pulmonary artery pressure. And the RV, how much in systole, how much pressure it has to augment to go across, pump across the pulmonary artery. So that is measured through tricuspid valve regurgitation velocity. If the TR velocity, that is tricuspid valve regurgitant velocity, is more than 2.8 meter per second, we generally consider it as a pulmonary artery hypertension has set in, and we have to go on with the starting of the treatment of the pulmonary artery hypertension. So various methods including TAPC, that is tricuspid annular plane excursion, that is another way by which we can assess the RV function. If TAPC is less than 1.8, the prognosis is very poor, and TAPC more than 1.8 centimeter per square, the prognosis is generally good when we start the treatment earlier itself. Similarly, when we are not able to get the regurgitant pressures, regurgitant blood across the tricuspid valve, we take pulmonary artery regurgitation, that is across the pulmonary valve. Pulmonary valve pressures can be measured with the continuous wave Doppler, and if it is two parameters can be assessed with the pulmonary regurgitation velocities. One is mean arterial pressure, and second thing is end diastolic pressures. Generally mean arterial pressures gives about the prognosis of the disease. So mean arterial pressures generally, when we grade about the pulmonary arterial pressure, 7 to 17 millimeter is graded as a normal, above 17 it is mild, 17 to 25, 25 to 50, and 50, above 50. It is I am telling about the mean arterial pressure. I am not telling about the peak systolic pressure, which I described in the tricuspid valve velocities. So depending upon the mean arterial pressures, we grade the pulmonary arterial pressures into mild, moderate, and severe. 17 to 25, 25 to 50, and more than 50 is graded as severe. These are the various methods by which we use echocardiogram to assess the pulmonary artery pressures. Management of RV failure will speak later. When it comes, we'll.
I think one question that I would really like to ask, there is a very good article in the NEJM 2014 May about this Chapase that he's talking about. There's a very big article on that. I think if you're interested, I think you can go and read it. It's of May 2014, it's in the NEJM. There's a huge series about 1,200 patients in whom they have used this entity of echocardiogram. The question that I'd like you to answer, sir, is as pulmonologists, how can we preserve right ventricular function? What should we do? What should not we do?
Carpulmonale, see, any disease we should treat the primary disease aggressively. That is the most important entity in carpulmonale. If you are getting a repeated exacerbation of COPD, the RV function is going to deteriorate very rapidly. So primary management of COPD is the best thing to preserve the RV function. Second thing is we try to reduce the workload of the RV by reducing the volume. You can use diuretics, especially loop diuretics can be used to reduce the volume and workload of the right ventricle. So previously, before 1995, we used to give only calcium channel blockers, which are called vasodilator therapy. So they try to dilate the vessels and try to help the RV functions. But after 1995, actually the pulmonary artery hypertension treatment has been entirely, the scenario has entirely changed. Now we have three arms by which we manage pulmonary artery hypertension. First thing is prostacyclin analogs. Second thing is epoprostenol group. Third thing is phosphodiesterase inhibitors group. So prostacyclin analogs are they have come out with a very good results actually. To say the thing, out of the three things, bosentan and ambrisentan have come out with a good outcome. And so the point of thing is it's very too costly. It comes around 100 to 150 rupees when you go for these prostacyclin analogs or bosentan group. It's too costly. Whereas the phosphodiesterase inhibitor groups are comparatively cheap when compared to other two groups. That is sildenafil and tadalafil have come out with such a good results, especially tadalafil. Sildenafil, what is the disadvantage is it is a short acting drug. It should be given at a dose of 3 times a day. When you give a dose of 3 times a day and when you slowly step up to 80 milligram 3 times a day, systemic pressure comes down. That is the main problem with the treatment of pulmonary artery hypertension. When you drop, when the systemic pressure comes down, we are not able to achieve the full target dose. So now they have come out with a solution called tadalafil, which has less effect on the systemic circulation, more effect on the pulmonary artery circulation. So it's a long-acting drug, and the off-life is around almost 17 to 18 hours. You give once daily and try to step up the dose from 20 milligram, 40 milligram. It can go up to the 80 milligram also. And the longevity, to say the truth, the longevity with the tadalafil is excellent, but the symptom relief may not be good with tadalafil when compared to bosentan and prostacyclin analogs.
But before these drugs, I think we have not talked about oxygen.
Yes, sir. Actually, there was a thing called vasodilator therapy, which has been tried initially. That is, actually, this vasodilator therapy, along with oxygen, nitric oxide synthase. You give inhalation of nitric oxide, you give inhalation of oxygen, and you give all those things are tried in 1995. They are called responders to the vasoreactivity. Vasoreactivity responders are respond very well with the calcium channel blockers, but the entity has entirely changed after 1995. Now these three groups of drugs have taken the role of management of the pulmonary artery hypertension.
I think Dr. Rajgopal is talking about home oxygen therapy, and I think it's so important that we realize that oxygen is not this end-of-life thing where they shove into the nostrils just before you take your last breath. Today, oxygen is a drug that we use tremendously usefully in patients with COPD. The principle with using oxygen would be try to identify these patients who who sort of retain carbon dioxide. That's important. A simple ABG will tell you the number of patients and how much carbon dioxide is retained. Two, don't hesitate to start oxygen early. And when you start oxygen, you please start what is called low flow oxygen. It's about 1 to 2 liters, and you start what is called nocturnal oxygen, which is the NOTT trial. You know, the NOTT trial from the BMRC has been going on for years, there's no question about it. 15 years we've known that oxygen is an excellent drug in patients with COPD who retain carbon dioxide, and I think we have not been using it. Today it's become very, very handy, very comfortable to use oxygen. We have people who rent out these oxygen concentrators. You can get them rented out. You can buy them for about 35 to 30,000 rupees to 45,000 rupees. You have a very good oxygen concentrator. It can make a huge difference with COPD. Please don't wait for a very, very long time till your patient has severe pulmonary hypertension and the 6-minute walk distance is very, very small. It goes into severe where F1 FVC falls below 30–40%, and then try to use the oxygen. That's not the time that you use the oxygen. The time to use the oxygen would be to try and use the oxygen pretty early, so that you get the best benefits of oxygen.
I totally agree, sir. Once the pulmonary artery hypertension sets in and it becomes severe, the response to the oxygen is really poor only. That is the fact. So try to start this oxygen, nocturnal oxygen or domiciliary oxygen therapy as early as possible so that you can prevent the aggravation of the pulmonary artery hypertension. So they are called vasoreactive responders. If they respond to the oxygen therapy, generally they respond very well, and they also respond to the calcium channel blockers. Poor responders are the people who don't respond to this type of oxygen therapy. So actually, to say the truth, pulmonary artery hypertension trials are done mainly with idiopathic pulmonary artery hypertension or pulmonary artery hypertension associated with connective tissue disorders. So carpulmonal, these drugs are extrapolated to the carpulmonal, that's all. As such, there is no direct clinical trial on patients with COPD and pulmonary artery hypertension. Whatever thing that is derived from idiopathic pulmonary artery hypertension, we are inculcating into the carpulmonal of COPD. That's the truth.
Well, I think it's very important that you pick up the pulmonary hypertension and confirm and reconfirm the pulmonary hypertension before you start thinking of drugs like sildenafil, bosentan and ambrisentan and things like that. And please make sure that the number of patients with pulmonary hypertension and COPD will be much, much smaller than pulmonary hypertension and IPF for that matter. If you take IPF, you get a lot more pulmonary hypertension in IPF than you get in COPD. This may not be the statistics in the West. It could be a little different. And so I think oxygen by itself would be my third appeal to you, to use oxygen as quickly as possible rather than wait for a long time. Dr. Sangeeta, would you like to say something?
So I would just like to add on that just how the cardiologists are using the PFT, we need to use a 2D echo too. Like somebody who has got a COPD and has been with you for a year or two, I think we have to, even at the outset, there's nothing wrong in asking for an echo. Even at the earliest sign of an carpulmonal, if there is the slightest change, that patient, if you put him on oxygen therapy, home oxygen therapy, you are able to prevent the progression of the RV dysfunction. So I think PFT and echo should go hand in hand so that you pick up those who have the early manifests of carpulmonal, and then you start them on a home oxygen therapy right in the beginning, not allowing them to progress into a severe carpulmonal. And also, like now you have the pulse oximeters which are available. Everybody uses, even our patients use them these days to monitor their oxygen saturations. So it would be very beneficial if we can have them in our clinics, so that when you see somebody who has got a resting oxygen of around 90, I think you have to start motivating them for an home oxygen therapy, so that it's not too late.
Yeah, I think oxygen would be a very important thing. We understand that, but as I said, we need to control the flow and things like that. Now, once we finish with oxygen, I think we'll deal with NIV, and I think I'll ask Dr. Raju.
The other non-pharmacological.
Okay, the other non-pharmacological would be pulmonary rehab, for that matter, if you can get a rehab. Now, I think a lot has been said about rehab in this country. We have a lot of literature on rehab, but rehab is an entity that's very, very difficult to put it into practice in a community like ours. You know, in patients in the West, for example, they're doing nothing. The hospital picks them up and drops them back and probably gives them a cup of tea in the middle. And that's the type of setup that they have, where all their entities, logistics are taken care of by the hospital. But in a family that is present in India today, you will find that both the husband and the wife are out, and the mother and the father are in, they are old people already, and you find that it's a logistic nightmare to get to a hospital to practice pulmonary rehab. So I think we need to teach these patients exercises which they can do at home, simple limb exercises and trunk exercise that can be taught at home, done for about 10 to 15 minutes. And you can encourage patients to do what is called the 6-minute walk distance. Today, the 6-minute walk distance has become probably the most important prognostic parameter in patients with COPD today. A simple 6-minute walk distance, if it's improving, your patient is improving. If your 6-minute walk distance is not improving, your patient is not improving. If you don't have the corridor to walk for 6 minutes, you can do what is called the shuttle walk test. Like you can ask him to walk from here up to the door and come back. How many shuttles do you do today? How many shuttles do you do tomorrow? That's really what it is. So I think the 6-minute walk test is an excellent prognostic index in patients with COPD, and I think we need to be using them. There are other prognostic indices like the board index, for example, but that's a little more complicated, where I need to use the MMRC scale and use another complicated scale. But I think even if you don't use the 6-minute walk distance, please ask the COPD patient to exercise, to walk, use his muscles, and I think that's important. It's extremely important to use that. So I think these are non-pharmacological entities that we will do. And before we close, and I've forgotten, do you think there's any role for theophylline today in patients with COPD?
If you look at the Indian scenario, I think it's a very good drug. Only I think the cardiac toxicity, Dr. Sadanandam will be able to tell how safe is to use this theophylline in Indian patient. And before, I think we have left out two other things in when you talk about non-pharmacological therapy. One is Dr. Sangeeta has told about all those vaccines and smoking cessation. Okay. Very important. I think you have a session on smoking cessation. Is it there today?
No.
No. Then those are the two important things. That also forms a part of the non-pharmacological therapy. You have to talk to the patient regarding quitting smoking. And I think you had an elaborate session on vaccines, pneumococcal vaccine and other things. Those two are the other non-pharmacological therapy. Am I correct?
Yes. No, I think just a word about smoking cessation is simply because sort of I'm very involved in this, and that's the reason why I think we should. The first thing in smoking cessation, I'm sure all of us have seen the 5 A's that we know: ask, assist, assess, and things like that. First is you should ask the patient if he's smoking or not, and that's important. And the first mistake begins here because we don't ask. We don't have the time to ask because we don't really listen to these patients at all. We are so busy doing our own work that this guy is sitting by my side and talking, "Doc, I got up at 4 o'clock in the morning, I had breathlessness, I went to the door, opened the door and I started breathing, I couldn't breathe, so I looked for a cup of coffee which I didn't find, then I drank a glass of water." And what are you doing? You're sitting and writing some case notes, the nurse is walking in with the sheet, the phone is ringing from home, you'll have to take something back home, otherwise you're left in the middle of the road. You know, there are so many of these logistics things that are involved here, and we are sort of multitasking at every level, and this guy is going on talking, you know. I got up at 4 o'clock in the morning. You know, this is important. We should stop all this bunkum and then start listening to this guy. And I think we need to understand there's a huge difference between hearing and listening. Hearing is when I hear somebody singing in the next room. I hear because I want to hear, not because I have to hear. I hear because if I don't hear, I'm deaf. That's hearing. Listening is when I want to listen to what you're trying to tell me. And I think we need to listen to this guy. Talk to him about oxygen. Talk to him about the NIV, for example. Talk to him about vaccination, for example. Talk to him about smoking, for example. Today there's excellent things available. The NRT itself is quite effective. Then you have Vernaculine, which is a very, very good drug that you can use. So I think there are a lot of things that can be done because we still understand that the only thing that can totally reverse COPD today is smoking cessation, not anything else. We understand that the other thing that we talked about today can improve the lives of patients with COPD. But I think it's smoking cessation that is probably the most important. As Dr. Rajgopal has said, I think it's very, very important that we do practice smoking cessation. Have we left out anything?
Theophylline. Yeah.
Excellent. You finished?
Yeah. No. Okay. Theophylline. I think Dr. Sadanand, you can just tell about the cardiac toxicity of the use of.
Yes, theophylline, whenever it's oral or it's given as IV. We are actually generally we get a call in the midnight for COPD patient. That patient has developed arrhythmia, some form of arrhythmia. Either it is atrial fibrillation or patient who already having pre-existing accessory pathways that land up in supraventricular tachycardias. And generally the response to them, we have to give drugs like, in case of SVT, we have to give drugs like adenosine, which is again going to exacerbate the COPD. Nowadays, it's better to avoid all this oral theophylline and intravenous theophylline because of the cardiac effects. Generally, it's better to go for a inhaled therapy than going for an oral or intravenous therapies.
But
once patient is labeled as atrial fibrillation, the thing is we have to start on anticoagulants. It may be a persistent or a transient. We will not be knowing initially. So we have to start on heparin. We are going to complicate the scenario by giving a drug actually. That's the biggest, the worst thing that can happen to a patient. You are going to give an anticoagulant. We don't know what is the duration. It is a transient or permanent therapy. AF, it is not, we are not going to deal it. When you have a better option, why don't you go for a better inhaled therapy rather than going for an oral therapy? That's the question.
I think IV theophylline is an absolute no-no. I think let's make it very, very clear today that those days where you sat by the patient and used those big syringes and then injected slowly, like drop by drop, and this guy used to stick his hand out and you need to find a stool to sit by his side. You can't stand for that long a time. And those syringes used to be massive, 20 ml syringes. I don't know if they exist any longer. But the fact does remain that IV is an absolute no-no. If you want to give theophylline today, you can use what is called low-dose theophylline. Low-dose theophylline has a couple of effects which could be beneficial. Number one, it's got a mild diuretic action, number one. Number two, it's got a muscle strengthening action, especially with the diaphragm as such. So maybe if you want to use oral bronchodilators, I would advise you to use a very, very low dose of theophylline, and that's what it is. And if you're using a beta agonist, that's the last thing that you should be doing. Please don't use oral beta agonists like salbutamol, 2 milligram for example. You'll probably have an atrial fibrillation and he'll be sort of dead by then. It's very, very important that we understand that oral drugs have a very, very little role to play in this sort of thing. And especially beta agonists are things that you need to be very cautious about. I don't think we should be using them at all.
And if at all using theophylline, I think ideally to use a sustained release form, so that the side effects are very much lesser.
Yes, sir. Sir, if you had this dilemma and you want to do one test, what will you do, sir? One test only. Anybody in the audience? Pardon me? BNP. Oh my God, you're in the US. Okay. Echocardiogram. Great, sir. I think you have a patient. Anything else? Simple one investigation to differentiate that. What did you say? X-ray chest. A simple chest X-ray will differentiate a cardiac failure from anything else. And that's what it is. And I think it's important for us to understand that it's these simple things that we miss, and these simple things are the ones that make a huge difference for us. We don't need to use BNP and all those other sort of things that go through the roof for these things. Simple things are important. I think that's a wonderful question, because many, many times if you don't know this patient already, you're stuck with that dilemma. You don't know what to do, and you're sort of in the soup as such. A simple X-ray in 10 minutes will tell you where you're standing. Any other questions? You can look at the JVP, sir. You can look at basal rals which are present. Probably look at the history maybe and make a reasonable diagnosis. But if you want to confirm, I think an X-ray is probably what is important. If you're in doubt, please send him to hospital. That's the best thing to do. In today's scenario, there's no point in holding on. If you're still in doubt as to whether you're on this side of the wall or the other, the best is to send him to hospital where he can get a chest X-ray.
Sir, drugs like AB Phylin have come into the market.
Okay, sir.
What is their role? Because you are telling not to use theophylline.
Yes, sir.
But all government hospitals give only that drug.
Yes, sir.
But what is the role of this one, but which is very costly, 13 rupees a tablet?
Pardon,
AB
sir?
Phylin.
Okay, sir. Okay.
I would like to answer the question. The pharma companies are not clear on what they are marketing. AB Phylin is a compound of a mucolytic and theophylline. So in the process, neither is it a potent bronchodilator nor is it a potent mucolytic. It is just a marketing strategy which is boosting it. As a molecule, it is not superior either as a mucolytic or as a bronchodilator.
Theophylline is an extremely poor bronchodilator, especially when it's taken orally, because it's terribly absorbed in the gastrointestinal tract. That is one. Second is the mucolytic that she was talking about has no evidence in patients with COPD. There is no guideline that will talk about mucolytics at all. It's only the companies that will talk about mucolytics. You talk about Ambroxol, then you talk about NAC. For example, the May 2000 of NEGM has a huge article on NAC. And I think it's important for us to understand that. Yes, sir.
Patients with cardiomyopathy and COPD are presenting nowadays more and more. How to treat them?
It's a double-edged sword only. We have to tackle both the things. Cardiomyopathy should be tackled taken as a separate entity and should be tackled with unloading the ventricle, increasing the diastolic filling of the heart by reducing the heart rate. All those things should be done. So previously we don't have any options for controlling the heart rate. Once you give bronchodilators, it starts, whether it is even with inhaled therapies also, heart rate used to go up. Now we have come with drugs like ivabradine, which controls the heart rate, which doesn't have any action on beta receptors. So such a nice drugs have come, and we have to tackle both the things. You try to come out unload the ventricle, improve the contractility of the ventricles so that cardiomyopathy part is taken out, and try to cut short the exacerbation of the COPD with the nice drugs. That will be the best solution.
Sir, can you just tell about this role of the value of BNP in differentiating a cardiac? Because it's a sentence where we have BNP.
Yes, actually.
Leave the cost.
Yes. BNP is one of the nice tool to differentiate between the various forms of heart failure and BNP. Various forms of heart failure, renal failure, and pulmonary causes. So as a diagnostic tool, if BNP level is less than 100, I am telling about a patient with a preserved renal function. When the GFR is more than 60 ml, and if the BNP is less than 100, the cardiac failure is very, very unlikely. In between 100 to 400, it's a gray zone where we will not be able to differentiate between the cardiac cause and non-cardiac cause. If it is more than 400, we are very sure that is 500 and above. It's very sure that is a heart failure only. Secondly, in case of renal failure, where metabolism of the BNP is varied, levels of BNP definitely is different. So up to 300 to 400 is taken as up to 300 it is taken as a normal level in a patient with a CKD, and 300 to 800 it is a gray zone where we will not be able to differentiate between the pulmonary cause or the cardiac cause, and more than 800 it's sure that it is a cardiac asthma only. So that way BNP is a nice tool, but definitely once you start utilizing in more and more, the cost is going to come down only. Like glucometer strips, initially it was very, very costly. But the number of population people who are utilizing the glucometer strips, the cost has come down. Similarly, government should take some action, and the more the utility, the cost is going to come down only. Definitely, another strategy is this marketing people only. The real cost of the BNP, it comes around only 200 rupees. Because I have an individual lab where I buy it in bulk, and if you do it, means it comes around 200 rupees only. The corporate hospital is selling at the rate of 1200 and 1300, that's all. Yeah.
I think the less we talk about the corporates, the better. So I think we'll leave the corporates in peace. Are there any other questions, please? Yes, ma'am.
So what about doxycycline, sir? Is it really safer than Derifilin?
If you're very angry with somebody, you can give him doxycycline. And give him doxycycline 400 milligram in the night, he won't sleep. He'll have tremendous tachycardia. And doxycycline, acebrophylline are all glorified eunuchs of theophylline, right? They make no sense whatsoever. Absolutely no pharmacological sense whatsoever. And I think it would not be pertinent to use such drugs at all because they have absolutely no benefit. Like she said, they're neither here nor there. They're neither a bronchodilator nor a mucolytic. And how in heaven can you combine a bronchodilator and a mucolytic, for example?
So majority of prescriptions which come from outside to me.
Yeah.
I have seen many practitioners writing oral bronchodilators both in asthma as well as in COPD cases, irrespective of what stage they are. What is your opinion on it, sir?
Done, madam. I think you have a very, very pertinent question in the sense that we abuse oral drugs. Let's be very clear about it. Whether we are pulmonologists or cardiologists or general physicians or whatever, we abuse oral drugs. And I think that abuse has to begin with us. And we have to get into this habit of trying to stop the oral drugs if it is possible because they are extremely toxic, and I think it's important. The doxycycline you were talking about is very pertinent. You give 400 milligram, you try taking 400 milligram a day in the night, I'm sure you won't sleep. And that's really what it is. The toxicity is far in excess of any effect it could possibly have. Any other questions? So I think we've had a very wonderful session. If there's anything that is left out, please feel free to talk to one of us. It's been a real pleasure to be here, and it's been a pleasure to sort of chair this session, and like to thank all my co-participants in this panel as such. Yes, ma'am. Sorry. Oh my God. Okay. No, life is a circle, sir. You go round and round, and then you don't really have no end at all, and that's what a cough syrup is. The cough syrup is a circle which has no end. You keep giving and giving and giving, it doesn't get better, you give it again, it doesn't get better, you give it again, it doesn't get better, finally you land up with codeine and he lands with constipation. No, cough syrups.
Cough syrup with bronchodilator.
Sir, oral bronchodilators are probably useful for children, yes, in their correct doses as such. Oral bronchodilators, whether as syrups or as tablets or as injections, I think are not so very good drugs for adults. Okay. Wonderful.
I'm a visa because I'm using all these things, but I don't really think that.
If you're using doxycycline,
yeah,
it probably means that you're not using your inhalers properly.
I'm right.
And you probably belong to that group.
Actually, possible to use the inhalers because I feel I get more tachycardia with inhalers than by using.
What inhaler are you using, incidentally?
So this one in my pocket now. This is Evohaler, Seretide 250, Salmeterol and Fluticasone.
Okay. How many puffs are you taking?
2 puffs morning, 2 puffs.
You still have palpitation?
No, I'm having more palpitation with this.
You have palpitation? Okay.
I used it yesterday.
Okay.
It caused more palpitation than using a doxycycline. No, she was.
Why don't you try some tiotropium, sir?
Anyway, I have heard tiotropium now.
Definitely, because if you have tachycardia, tiotropium is something that will bring down your heart rate. It's an anticholinergic and will bring down your heart rate. I would request you.
Actually, my doctor is sitting here. Dr. Subramaniam is there.
Let's not work it out this way, sir. I'm sure there's a better way of working this out. There's a better way of working this out. But I think if you add the tiotropium to that, your heart rate could come down. Your heart rate could come down. Either add or substitute. One of these two things are important. But you're very right in the sense that you don't have the the sort of tachycardia associated with oral bronchodilators. It is an individualized effect. There are a lot of people who tolerate very high doses, but I was talking about the majority. You're probably the exception rather than the rule. That's fantastic. Yes, Thambi.
Sir, there are most prescriptions like Montelukast, levocetirizine combination, and sometimes prescribed with mucinac, N-acetylcysteine, sir. Both has an opposite action, sir. Because levocetirizine has a dryness of the secretion. It produces it has a lytic softening the secretion. So how those combinations are frequently prescribed by the chest physicians? Is there any effective for the COPD patients?
Life is not about what things you do, but how you can do things differently. It's a classic example. Both are useless. Both are absolutely useless. Whether you're talking about N-acetylcysteine, or you're talking about Montelukast, or you're talking about antihistamines, they have absolutely no role in COPD whatsoever. So there's no question of that, and I think India is the only country with the combination of Montelukast and levocetirizine, and all the other antihistamines that you're looking at. You've got desloratadine, you've got fexofenadine, you'll have every single logistic inside. And I think the computer, probably tells them what to add with what, and then they come out with the drug as such. I think it's an absolutely meaningless way of looking at things. Textbooks will mention about Montelukast, textbooks will rarely mention about combinations. Montelukast is an established drug, there is no question about it at all. But Montelukast is a drug that is used in asthma, and it's a drug that's got a very specific, narrow indication in patients with asthma and rhinitis maybe. Yes, Thambi.
DSLS activity, and it helps in unlocking the steroid resistance.
Yes, sir, you're very right. The so-called HDAC theory that's been put out.
Yes, sir.
Yes,
exactly.
The HDAC theory that's been put out. Two things I think you need to understand. Number one is that the dose of theophylline that you need there is extremely preposterously high. One. Two is that theophylline is very poorly absorbed from the gastrointestinal tract, which means you will have to use IV theophylline, and God forbid you. And I think if you use IV theophylline, I think if you really run into a problem with IV theophylline, believe me, you will never use it again in your life. Whatever it is, there is no question that the dose to unlock the HDAC will be very high and be preposterous really. I don't think it's a logical solution.
A 50-year-old gentleman diagnosed with COPD who has only the occasional exertional breathlessness, should he be on treatment all the time or only during the exacerbations he needs to take treatment?
If you diagnose a COPD itself,
he's a non-smoker,
which means you're looking at spirometry. If you make a spirometric diagnosis of COPD, I think it is better to initiate treatment rather than keep quiet, because we understand that once you make a diagnosis of COPD, after that it's a sort of downhill pulmonary function testing that you're looking at. It's a downhill breathlessness that you have. You've already entered that phase where you're going to downscale, and all that your interventions are going to do is to reduce this effect of decrease in FeV1 FVC that you're really looking at, so you will jolly well start him on treatment.
So as sir said yesterday, that asthma and COPD are two ends of the same disease. So we get a lot of patients who are poorly treated asthmatics who end up in COPD. So for them also, do they need to be on treatment throughout?
You're very right, in the sense that asthma is not COPD. They are very different. No, one minute. Let's get this sorted out. Asthma is not COPD. Asthma is different, COPD is different. Endpoints in asthma treatment are different. Your endpoints in asthma treatment are normal lung function. Endpoints in COPD treatment are not normal lung function. You're never going to get normal. Your endpoints of two diseases are poles apart. There is no question about it at all. The fact does remain that there is a small gray area of overlap, which is what you're talking about. We have known this for a very, very long time. There's no doubt that we have known this for a very long time. And it's only now the guidelines have put in this question of the asthma COPD overlap syndrome, as they like to call that, and they've put it in there. But whatever it is, if you're looking at an asthma COPD overlap syndrome, the best thing would be long-term therapy. There is no doubt about it at all. Absolutely.
Thank you, sir.
Sir, what's the role of IV steroids in acute exacerbation?
An acute exacerbation itself says that there is an immune system which is working over time and there is an increased inflammation. So definitely every acute exacerbation has to be treated within a steroid. If the patient is stable, you can even use an oral steroid, but if the patient comes with severe hypoxia or respiratory failure, then if it's an inpatient, you have to give an IV steroid.
Choice of steroid, ma'am?
You can choose based on the economic strata. There is no superiority of one over the other, but relatively methylprednisolone, it works better.
Thank you, ma'am.
Well, I think if we're looking at an exacerbation, I think we need to differentiate between infective and non-infective exacerbations. There is something which is called a non-infective exacerbation of COPD, and I think we should never forget that. And that simple total count will tell you whether you're dealing with an infective exacerbation or a non-infective exacerbation. We've seen patients with prescriptions of multiple antibiotics. His total count is 5,000. And I think it's a ridiculous way of looking at things. A simple total count will tell you whether you're here or whether you're there, whether you need to push your antibiotics or whether you don't need to push your antibiotics. And I think it's very, very important. And we also understand that there is what is called an infective exacerbation phenotype. There are people who exacerbate more than the others. Today, people have started talking about phenotypes in COPD, like there is an emphysematous phenotype. There is a chronic bronchitic phenotype. There is an exacerbator phenotype. There are a lot of these phenotypes with certain clear-cut scientific behaviors that are involved. Any other questions, please?
Sir, different clinical differentiation from cardiac dyspnea and pulmonary dyspnea.
Clinically. See, cardiac dyspnea, actually you can go by history itself. History will clearly differentiate between both the things. Cardiac dyspnea, there will be underlying coronary artery disease or cardiomyopathy. That doesn't set in a single overnight actually. You will have a history associated with exertional angina or rest angina. Usually patient landing up in heart failure, they have a history of PND initially for a short period, then only they will go for an orthopnea. So similarly, COPD also, depending upon the history only we can, it is not a overnight all of a sudden he is not going to get an acute exacerbation. He will have a recurrent respiratory tract infection or cough with things. Slowly he goes for an acute exacerbation episodes. So history by itself can make a differentiate. Again, by clinical examinations and investigation wise also we can make a differentiate between the COPD and the cardiac asthma. Generally cardiac asthma, they have clinical signs of heart failures either in the form of pedal edema or raised JVP, and auscultation wise we will have a bilateral crepitations, which in COPD the incidence of crepitations are very less. There will be more of wheezers only. Similar silent chest or wheezers. It can be those, so by clinically also we can differentiate. Again, ECG is a good non-invasive tool which is going to tell you about the nature of the heart disease. So poor progression of R waves is an entity where you have a dilated LV and they will land up in heart failure. Whereas in COPD, definitely you can make out a tall P waves. And next step is where you can differentiate with the ABG and echocardiogram. All those things comes in EQ. So simple history, clinical examination and non-invasive investigations including ECG and echo is going to make a differentiation between this. As sir told, no, chest X-ray. Definitely chest X-ray is not the least. It is the first thing to be done in a patient where you want to differentiate both the things. So this will help you to differentiate between cardiac asthma and COPD.
One question.
Please, sir.
Yeah, it's not related.
Sir, 1 minute. If I'm not too curious, are you using a spacer or not?
I'm using a spacer. I didn't bring it now. I'm using a spacer.
Wonderful. Great. Appreciate it.
Yeah.
Last question.
Yeah, something, it's about bronchiolitis. We used to use a nebulizer for bronchiolitis. I mean, what was that particular drug? I just wanted to, for bronchiolitis in children, a particular antiviral drug used to be added to a nebulizer.
I'm sorry, sir, I have absolutely no idea. If anybody in the audience can answer that question, be very happy. RSV, respiratory syncytial virus, okay.
Yeah, do we still use it?
I have no idea, sir, I'm sorry. If there are no questions, there's one hand, we'll finish with that. Last one. Yes? Pardon me,
Sir, in patients with asthma with airway remodeling, to segregate them from COPD cases like?
No, that's really what we're talking about. This population is probably the overlap syndrome population that we're really talking about here. If you really want to demonstrate airway remodeling, you need to use a bronchoscope and get some mucosal biopsies as such, and then you find. But the fact is that if you get airway remodeling, you will find that reversibility is becoming less and less.
Yes, sir. That is why.
That is really the question. Yes, if your reversibility becomes less and less, your asthma control becomes poorer and poorer, and you will find that these patients are becoming sicker and sicker, and their effort tolerance is decreasing. That's really the problem. It means that they're sort of progressing from a bronchoreversible state to a not so very bronchoreversible state. That's the problem.
Yes, sir. So we can ease like treatment, however we try for them with bronchodilators or something like that, even they progress as same as COPD, their lung function deteriorates. You just mean to say like that, sir? Like asthmatic subjects also not responding to bronch.
Okay, you're probably looking at something like maybe you've had steroid resistance to begin with. You have an ICS resistant asthma, which is about 3 to 4% of asthmatics have a resistance to inhaled corticosteroids. You're probably ICS resistance, or you go into one of those, or what shall I say, bad asthma states as such, you know. The severe asthma phenotype, as I like to call that. A severe asthma phenotype could have many reasons. IgE, for example, I think is one thing that you may have measures. Omalizumab is a drug that you could try in such patients. They may have, if you have high IgE levels, you can try omalizumab. It brings down at least the exacerbations and the steroid doses that you need to use in these patients. I think we'll stop with that. Thank you very much. It's been a wonderful 1 hour to be spent here in the afternoon. It's been a pleasure. It's been a pleasure and a privilege to have a distinguished panel like this. I'll just leave you with one thought that William Osler said years ago. Don't treat the disease. Treat the patient who has the disease. Thank you very much and good afternoon.
I would like to thank Dr. P.K. Thomas, the moderator for the session, and all the panel members. As a token of our appreciation, we would like to give a small memento to Dr. P.K. Thomas, Dr. Sadanandam and Dr. Sridev.